Okay, I want to welcome you again to today's tutorial. My name is Geoffrey Mtale, as you can see down there on that slide. And again, I want to take this opportunity to thank you for all that you do by liking my YouTube channel, watching the tutorials I make, and then sharing the link to different people so that they can also benefit from these presentations. So for today's presentation, we are going to be discussing about tissue processing. Yes, we have talked about tissues in the previous presentations, and today we need to look at what we mean by tissue processing. So just like the name goes, this is the procedure that we are going to take the tissue into from the time it is harvested from the body, the time it is actually put on the microscope slide and can be examined under microscope to look for any pathological changes that we can be interested in. So in this presentation we shall be looking at the tissue processing, which will begin with the fixing, because we understand that the moment you pick a tissue or you receive, it must be fixed immediately to prevent any postmortem changes, that is autolysis and putrefaction, from happening. And then again we shall have to look at dehydration, which is simply a process of removing the water that is in the tissue, because remember the tissue has water in it and we need to remove that water, because that water in the tissue is not miscible with some of the chemicals we are going to use, like for example the embedding media is not miscible with water, so we need to remove. And then we also have to talk about clearing, and clearing in brief, this is removal of the reagent or the chemical, and basically these are the alcohols that we are going to use in the hydration, because these alcohols are not actually miscible with the bending and the infiltrating agent, so they have to be removed from the tissue so that the tissue can be infiltrated. And then when we talk about infiltration or impregnation, and this is making sure that the tissue block is infiltrated, or the embedding media or the wax enters the tissue so that it can be firm enough. And then we talk about the last procedure that we shall discuss here, and this is what we call the embedding process. And in embedding we are going to look at putting the infiltrated tissue or biopsy into the mold and add excess molten wax so that it solidifies and makes what we call a tissue block. So those are the processes we are going to be looking at in today's presentation. So let's start straight away. So tissue processing basically refers to the process of removing water, just like I mentioned before, from the tissue after fixation. And this is done because water does not mix with the media used to hold the tissue during microtomy. And the media we're talking about, this is going to be the molten wax. The wax is not miscible with water, so we need to remove excess of the water which is in the tissue, and then we shall look at which type of water we actually remove from this tissue, because we have the free water in the tissue and then bound water. And this is the principle of tissue processing. Actually, the principle of tissue processing is ideally to remove the primary idea is to remove the excess water, or to remove water in the tissue so that it can really mix well with the embedding media and with the infiltrating media. So tissue processing ideally involves passing tissue through the processes of fixation, dehydration, clearing, and impregnation or infiltration. And this is what you need to know, that irrespective of the method you're going to use to process the sample, the basic principle remains the same. Whether you're going to process the sample using automatic processors or manual processors, the principle or the procedure will always remain the same. It will always start with fixation, followed by dehydration, clearing, and then impregnation. and all these have different purposes, just like we mentioned before. So the first step is essential to prevent autolysis, and this is the first step of fixation. Autolysis and putrefaction, or it will stop the postmortem changes which may occur, and this would destroy the diagnostic elements and to prepare the tissue for the rigors of the reagent that is in the subsequent processing steps that will happen, because from there the tissue is going to be subject to a number of processes, and some conditions are harsh, like we have to expose it to heat, so it has to be prepared for those other processes that will come. So let's look at the factors which influence processing, or which influence tissue processing. And for those actually who have watched or attended my presentation when I was talking about tissue fixation, you will realize that some of these factors are the same, because fixation is part of tissue processing. So the factors we discussed, like the size of the tissue, concentration of the fixative, the time, the pH, osmolarity of the medium, all these are going to also surface here, because fixation is actually number one procedure in tissue processing. So when tissue is immersed in a fluid, there is an interchange which occurs between the tissue's internal fluid and then the surrounding solution. So the rate of fluid exchange or diffusion is actually dependent upon the tissue size and density. For tissues which are small, the rate of exchange is higher compared to those tissues which are thick or which are dense. Whereas physical properties and the concentration of the processing reagent are also very important. So we look at this and appreciate that several factors influence the rate at which diffusion occurs, and this could be temperature, viscosity, pH, the size, concentration, and many others. So I will refer you to my presentation when I presented about fixation, so you can look around on my YouTube channel. You look around for the presentation about fixation, and then you get. But going through this very fast, like for example viscosity, we appreciate that a solution with low viscosity has small sized molecules, and these molecules move faster, and this means there is a higher rate of penetration, and they can fix or infiltrate the tissue very well. Conversely, solutions with larger molecular weight or with large molecules have high viscosity, and the exchange rate is slower compared to those with small ones. So most of the solution used in processing, dehydrating and clearing, we actually prefer those with similar viscosities and smaller viscosities, even those used in embedding media. However, they have various viscosities depending on when we want to use them. Like for example, the viscosity of the embedding media may actually not be the same. So moving forward, another factor what we looked at last time when we talked about fixation was agitation, and we appreciate that agitation will increase the flow of solutions around the tissue, and in that way, increasing the flow, it also increases the rate at which these molecules penetrate the tissue. We also talked about heat in that presentation, and we know when there is heat, it will increase the movement of the molecules, the atoms in the fluid, and whenever there is increment in the movement, in the mobility of the molecules of the atoms from one place to another, then they also increase the rate at which they can penetrate the tissue, so easily penetrating and for easier processing. So another factor is vacuum. We shall also look at some of the equipments we use in tissue processing, and we shall appreciate that some equipments have a vacuum and pressure, and this vacuum actually aids easier penetration of the fixative or the embedding material or the infiltrating substance into the tissue easily. When a vacuum is created and there is pressure, it will facilitate easier penetration of the infiltrating chemical into the tissue, and it will be infiltrated quickly. So vacuum aids in the removal of air pockets in the porous tissue, because Actually, when we process tissues and we are infiltrating them, and there are some tissues, like for example the lung you're talking about here, you remember the lung has air pockets like in the alveoli. So with the pressure and the vacuum, it can easily allow the infiltrating chemical to fill up these porous pockets, and we have a solid tissue infiltrated properly, and this can be sectioned, and we can get homogeneous sections on sectioning. So the processing solvent contamination is also very important. This also can affect, because if you are processing with the fluids and solvents which are contaminated by other chemicals, it means it will reduce its efficacy, or if it is diluted. In addition, also to the size of the tissue, the type of the tissue, and the number of runs that are used. So use of sponges and cross contaminations of processor solvents will influence how often solutions should be rotated between stations or changed to maintain the processing quality. So these are policies which should be set up in the lab, that after a particular period of time we need to change the processing solvent depending on the size, the type, and then the number of runs that we have carried out. So before we go on, we need to put some consideration. So these are points we need to consider before carrying out tissue processing. So number one, we need to consider the size, and this we appreciate that small fragments of tissue should be wrapped in filter paper and placed in tissue cassette so that they do not actually get lost during tissue processing. Sometimes we receive very small samples in the lab, like for example we may get some true cuts, some scrapings. These are really very small, and they can actually disappear. They cannot be put in the cassettes. They can go through the pores of the cassettes. So during the process of processing the tissue, they can be lost. So to avoid losing such tissues, we really need to wrap them in a filter paper and then put them in a cassette, and then we continue to put them in other processing reagents to avoid losing them. So we need also to look at the volume of reagent, which also should be between 15 to 20 times the volume of the size of the tissue. And this is very important, most especially when we come to fixing. To ensure proper fixation, at least the tissue should be put in a fixative, which is about 15 to 20 times in volume higher than that of the tissue itself. So all tissue to be processed should be accompanied with the required information. For example, the lab number, particulars of the patient from whom the tissue has been picked, and these numbers assigned should actually follow up with the tissue up to when the report is given. So if heat is to be used in emergency cases, then care should be taken that the solution does not actually boil, or we shouldn't actually cook the tissue, but we need really to use optimal temperature for easy processing. So we need to look at tissue processing stages, just like I mentioned it before. So in these stages we have fixation, which prevents autolysis, dehydration, which is for removing water, clearing is displacing the dehydrant, and we shall look at the different dehydrants, and then infiltration, which this permeates the tissue with a supporting medium. And here we need to take note that the infiltration reagent or chemical should actually in most times be the same as the embedding medium, so that there is matching. And then the last step will be embedding, or orienting or placing the tissues in a supporting medium using a mold, so that we can have a solid block that we can mount on the microtome and carry on with the sectioning. So last time we discussed fixation, and I'm not going to spend much time on fixation, but still I will refer you to my tutorial. You can look for it about fixation, and then you really go in detail the procedure of fixation. But the main purpose of fixation is to prevent post-mortem changes which may occur, and these autolysis and petrification, which may actually make us miss some of the elements which will be significant in diagnosis. So we need to ensure that we keep it in a state which is as good and almost similar to how it was in a normal living state, so that we don't miss out the features, among other things that you see when you watch that video. So the tissue should be dissected to about 2 to 4 millimeters, and this is this is the optimal size, so that the fixative can easily penetrate the tissue and fix it well. So bigger sizes of the tissues will take long to be fixed, or can be incompletely cannot achieve complete fixation, which can affect. And one of the things we talked about last time, that when the tissue is incomplete, is not fixed well, the staining will also become hard. So let's get to another step. This is step 2, and this is dehydration. Just like the name goes, we are removing water. So dehydration purpose is to remove water, and this is the sole purpose why we need to do tissue processing, is to remove excess water, so that the tissue can be actually permeated with the molten wax to make it hard, and it can be actually put in a mold, and it can be sectioned well. So dehydration replaces the residual fixative, which is in the first case. If we use 10% formalin, it's going to be displaced as a cellular water, and then water which is found in the tissue is also going to be displaced. And this water, I said, it is in 2 forms. This way we have the free and then the bound water. So the bound water molecule is an integral part of the molecules of the cell. It forms part of the cell, it forms part of the nuclei, and we cannot remove this bound water in the cell, because the moment we remove this bound water in the cell, then we are interfering with the constituents of the cell, we are interfering with the morphology of the cell, and in the end we may end up getting shrinkages, which may actually give us a proper diagnosis because of poor processing. So during dehydration, we target just to remove the free water and not the bound water. So correct dehydration schedules during the tissue processing should only remove free water and leaving the unbound water intact. And in this process, we use graded alcohols from low percentage to higher percentage, so that we do not cause rapid dehydration, because it can have effects, it can cause artifacts, it can cause shrinkage of the tissue, which may not be good. So we need to take that in consideration. So when tissue exposed to heat or excess time in higher grades of alcohol, like for example 95 or 100%, bound water is removed, which we really don't want to do. So most of the time we limit the time the time in which the tissue is subjected to the dehydrant. In this time we are talking about alcohols, and again we need to regulate the temperature, so that it is only the free water which is removed, but not the bound water. Because when we remove the bound water, this will provide or produce overprocessing artifacts such as shrinkage, we mentioned this before, the parched earth effect, and abnormal staining, as well as dry brittle tissue during microtomy. So for this reason, specimens are best processed through graded alcohols of increasing concentrations. We start with low concentration, like for example we may start with 70%, 75, go to 80, 90 and 95, or what we refer to as absolute alcohol. So dehydration has also its shortcomings, because when we do an incomplete dehydration, this will impair the penetration of the clearing agent in the first case into the tissue, and this will leave the specimen soft and non-receptive to paraffin wax infiltration, and this will not be good. So we must ensure that dehydration is complete, so that we can get good sections at the end. So glycerol ether dehydrant an effective alternative to alcohols. Alcohols are the most. I think you also go and look at my presentation on dehydration specifically, and then see what happens in dehydration. But here we shall cover some few and mention some few types of dehydrants as we go on. So unlike alcohol, glycerol ether are unable to act as secondary fixatives, but their chemical properties prevent removal of bound water. So over processing is actually prevented. That's an advantage that you need to take note, but we can get to actually learn more about it when you visit my presentation specifically on dehydration, and then we see the different kinds and the different types of dehydrants and their different mode of action. But briefly, for to go to basically talk about the mode of action of dehydrating agents, we shall mention a few. And here we look at dehydrating agents which remove water in two ways, and these two ways are that some of the dehydrants are hydrophilic, which means they are water loving, so they attract water themselves, and that is how they remove water from the tissue. And whereas other reagents dehydrate by repeated dilution of the aqueous fluids in the tissue. So they repeatedly, the solution repeatedly dilutes the water in the tissue to an extent that water is removed by not having an effect. It's diluted to an extent that it's no longer water. So that's how these two methods and the two modes of action actually happen when we are dehydrating. So we have examples of dehydrating agents that we use, and number one, we have ethyl alcohol or ethanol, and this is the most commonly used dehydrant. We have methanol or methyl alcohol, we have acetone, isopropyl alcohol, butanol, and many others. So we look also at the additives which are used in dehydration, because sometimes we add some additives, and this can facilitate quick dehydration. When we add these additives, they can help us, one, to either enhance the dehydration process, or two, some additives are added to help us actually detect whether dehydration has taken place completely, to determine the end point of dehydration. Like for example, here number one, we have anhydrous white copper 2 sulfate, and this is actually important to help us determine the end point of dehydration. So this is placed in the last changes of absolute alcohol during dehydration to detect whether dehydration is complete or not. So when dehydration is complete, the copper 2 sulfate retains its white color, indicating that the concentration of alcohol has not been compromised actually. But when there is color change from white to blue, this indicates compromisation of alcohol concentration, or alcohol is no longer absolute. Therefore, dehydration is incomplete. That's what it means for that case. So another additive which you can actually use during dehydration, these are hygroscopic substances, and these have the ability to absorb water. If you remember the hygroscopic substances in our basic science, we studied from the different levels. So these absorb water from the atmosphere. So how they act is that they are placed in absolute concentrations of alcohol, such that any water droplet from the atmosphere do not dissolve in alcohol, but rather these hygroscopic substances absorb them, such that the concentration of absolute alcohol remains as such same, e.g. calcium oxide. So they also help to maintain the concentration of alcohol. And then number three, we have the phenols, and this is added to dehydrating agents and act as a softening agent for hard tissues such as tendons. So these ones actually facilitate, so that when they make the tissue very soft, then the dehydrant can penetrate the tissue very well and remove the excess of the water which is in the tissue. So this can be used in tissues like tendons, nails, the dense fibrous tissues, and the keratinized muscles. These are used at a concentration of about 4%, which is added to 95% ethanol, and this is taken as absolute alcohol. Alternatively, hard tissues can be immersed in glycerol or alcohol mixtures. So what are the advantages of using ethanol as a routine dehydrating agent? Because just like you saw, we have a long list of dehydrating agents, but why do we prefer ethanol as the best dehydrant? One, it evenly and quickly penetrates the tissue compared to other dehydrants. That's an advantage, because we want a dehydrant which is going to give us a picture that is going to be useful diagnostically. Number two, it causes less cell shrinkage. Yes, and this is very important because we need to examine the cells which have their morphology maintained almost similar to the state in which they were in before they were removed from the body. And then number three, it is readily available. So it is always good to use reagents which can easily be got, so for continuity, instead of getting something and then you can not get it again. Number four, it causes less extraction of cellular components from the tissue. Yes, and this is also very important because when we dehydrate, we need not to lose most of the components of interest, like for example fats, some lipids. We may not need to lose them. So well, alcohol dissolve some but do not remove them completely. So we need to use a dehydrant which does not actually render the tissue devoid of some elements of importance that we may need to study, and they are not there. So, and lastly, it is relatively affordable as compared to the other dehydrating agents. So this is also very key for cases of continuity and affordability. This means that even our costs in the different laboratories for tests will be cheap, and this is good even for the patients who are actually receiving the services. So apart from dehydrating, we go to our next step. You remember we said you are going stepwise. We started by fixing. From fixing we went to dehydration. These are the steps which are following each other chronically, and then we are now on the next step, which is clearing. So clearing agents must be miscible, one, both with the preceding anhydrous alcohol, which is a dehydrant, to effectively remove them. Because now we want to remove now the dehydrant which removes the water. Now the dehydrant, which was the alcohol, is also not miscible with the infiltrating substance. So for us to infiltrate the tissue well, we need now to remove the dehydrant, which is alcohol. So now we need to look at a clearing agent which is miscible with both, and in this case it can remove the dehydrant and then making sure that the paraffin wax also can be allowed to completely infiltrate the tissue. So a good clearant will also dissolve lipids which can impede the wax from penetrating. So many of the histological solvents are not suitable for histological processing today due to the extremely hazardous nature and or harshness to the tissue. So we shall also look at a number of some of the clearing agents, but some clearing agents are very poisonous, meaning are carcinogenic, they are corrosive, and some have very harsh treatment to the tissue. So xylene is the most commonly used because it is less hazardous, less poisonous, and just like we looked at the dehydrant, also it is readily available and easy to get. So examples of clearing agents, we have a long list here, and with the xylene on the top being the most commonly used. And then we have toluene, benzene, chloroform, the BioClear, carbon tetrachloride, carbon bisulfide, methylene benzoate, essential oils, and these may include the clove, originum, sandalwood, and then the cedar wood oil. These all can be used as clearing agents among many others. But then our interest is using a clearing agent that can be easily affordable, that can do the work that we want, that can remove and is miscible with both the dehydrant and then the infiltrating agent that we are going to use, because we want to infiltrate the tissue with the wax. So chloroform do not harden the tissue, but was not approved for use on earlier closed tissue processors because it could dissolve the plastic components. So it would have been a good clearing agent, but some other effects which happen with some clearing agents, they make them not good for using, because chloroform, like in this case we are saying, it can dissolve other plastic components of the equipment, the machine. And if we shall look at the automatic tissue processor, it has some plastic components, not all metallic, just like we appreciate most of the machine. So using chloroform would actually dissolve some of the components of the machine, rendering it not good for use. So we list it is on the approved reagent list for new processor models. The downfall is that chloroform is carcinogenic, so nobody would want to expose him or herself to a carcinogenic agent that would actually cause problems in the future, that somebody develops cancer. So today xylene is the most widely used clearing agent in tissue processing. It is an excellent lipid solvent but has the negative characteristic of drying tissue specimen. Yes, xylene can dry specimens very well. It is very volatile in the first case. It can evaporate quickly, and it can lead to drying and causing some artifacts if not handled or not used very well. So we need to always use it quickly and avoid the drying and hardening of the tissue. So xylene is practically insoluble in water and therefore is capable of removing water from the tissue, especially in the longer clearing times needed for fatty tissues. So properly dehydrated tissue at this point in processing has only bound water. We have already removed the free water, and the removal of this causes excess drying. Alternatives to xylene exist which are less hazardous to health. Like for example, the most common of these are citrus-based clearants and aliphatic hydrocarbons. These are very good alternative to xylene. So the citrus-based clearant, with examples like chlorine, we have the Hemod, we have the Histoclear, the Masterclear, Histosolvent X, the Americlear, the Citrisolvent, Citriclear, Citrus Clearing Solvent. These are all made from the D-limonene, and in this, the D-limonene has a characteristic citrus odor, and that's where it gets the citrus-based clearant, because that odor is similar to that of citrus fruits. Citrus, when we talk about citrus, we mention about orange, lemons. So that smell of an orange is the one which is similar to that of the limonene. Okay, so some limonene clearants are marked as grass, which is actually in full regarded as generally regarded as safe. So generally regarded as safe, this is a marker which is put on these limonene clearants just to indicate that they are not carcinogenic, they are not very hazardous, and they are good for using. So apart from the limonenes, we also have the aliphatic, and these are straight chain hydrocarbons which are not soluble in water, and because they cannot remove bound water, they do not dry out the tissue. Remember the other one we said they remove and they cause drying out of the tissue. So for these ones, they don't dry out the tissue. But most aliphatic hydrocarbons are practically odorless. Though the others have the citrus smell, these ones are odorless, non-sensitizing and non-irradiating to the skin. The degree of oiliness and flammability, if any, is dependent on the carbon chain length. So we move now to our next step of tissue processing, and now this is what we call infiltration. So let's talk about infiltration. Infiltration, just like the name goes, it means permeating the tissue with the molten paraffin wax. So paraffin wax is the agent of choice that we shall use in infiltration. So after clearing the tissue, removing the dehydrant, these sections are infiltrated or impregnated with the paraffin wax to support the tissue, allowing thin sections to be cut at the end. So infiltration must be sufficient to displace the clearant. The clearant in this case we have been talking about xylene from the tissue. Otherwise, the wax will not harden properly and it interferes with microtomy. So if you are going to make sections out of a block where the tissue has not hardened properly, then you will not get good sections. Yeah, there will be compressions, lines could appear in the sections, and smudging, so you cannot actually get good sections. So tissues which are not allowed to infiltrate for long enough will be soft and crumbly, making sections difficult. It is not easy to make sections, actually even impossible. So too much time in higher temperature wax can also cause excessive shrinkage and produce dry, brittle tissues, which are equally difficult to section. So appropriate time needs to be given so that we don't under or over infiltrate. So wax selection should be based on the density of the tissue it must support. So you realize that the wax is also in different categories, and we also realize that different brands of wax also may have different temperatures and different densities. So this is going to typically depend on the tissue that you're going to impregnate. So low melting point wax typically has higher paraffin concentration and will provide a softer matrix. Yet waxes with a higher polymer content produce a harder matrix, which will mimic dense tissue more closely, and then depending on the tissue you want to impregnate, a choice can be made based on that. So infiltration is complete and tissues are embedded into paraffin wax block to enable sectioning on a microtome. We shall look at details on embedding, and then we see how we embed these tissues. So the temperature of the embedding paraffin wax should be at least 2 to 4 degrees above its melting point, because this is going to enable us position, because when we embed we are going to lay or to orient our tissue in the mold in a specific at a specific plane, in a specific order, depending on the type of the tissue and depending on what we are interested in and what we need to expose on a microtome when we are making these sections. So overheating of the wax can cause hardening and distortion of the tissue and even break down the paraffin additive, like for example the resin polymer, which may result in a poor performance. So we need to note that it is also compatible with most of the routine and special stains, including immunohistochemistry protocols, and paraffin wax is inexpensive, provides quality sections, and is adaptable to a variety of tissues. Above all, it stays for long. If you impregnate and embed your tissue in paraffin wax, it can stay for years and years when it is still good, and can be used for a number of tests, including the immunohistochemical tests. They can also be done on paraffin embedded tissues. So apart from the paraffin wax, we also have the water soluble wax, and this is what we call the carb wax. So this is different from the paraffin wax in that the paraffin wax was water insoluble, but we are talking about the water soluble wax now, what we call the carb wax. So in this is an impregnating media which is water soluble, and in this case there is no need to dehydrate, because the purpose for dehydrating in the other side was like the paraffin wax was not miscible with the water, but given that this one is mixed with water, so there is no need for dehydrating and clearing. These steps are avoided, but the tissue would actually be embedded or would be impregnated directly. Therefore, after fixation and crossing, the tissue is directly taken for impregnation and embedding. This works given a short turnaround time compared to paraffin wax. That's one of its advantages. So we shall be looking at some of these procedures in our subsequent presentations about embedding. Embedding and then grossing. I think we need to cover grossing. I've mentioned it a number of times, but I need to take you through grossing, and then we know what really grossing means. So advantages of using water soluble wax. One, we have mentioned the one, it saves time since the tissue does not go under other process of dehydration and clearing and so on. So it is good to use when the enzymes that are sensitive to heat and to be studied in the tissue. If we are going to study some immunohistochemical tests, this would also be good. And it also causes less shrinkage of the tissue as compared to paraffin wax. That's very good, and good for demonstrating lipids since there is no clearing, and most of the clearing agent is all of fats. So here we don't miss out the fats. There could be the elements of interest that we need to study. So using carbo wax can be very important. So which other alternative infiltration media can we also use in case we are not using the carbo wax or the paraffin wax? So occasion is when paraffin wax is unsuitable medium, we have other alternatives which you can use. So processing reagents will remove or destroy tissue components which are the object of investigation, like for example the lipids, and this can be actually done away with the clearing agents, but we have seen that when we use some other infiltration chemicals like the carbo wax, it preserves them because we shall not need clearing. So the use of heat may have an adverse effect on the tissue component, like enzymes. They can be destroyed and then we miss them out, yet they could be they could be markers of interest that we need to study. But depending on the process we take the tissue in, we may lose some enzymes when we expose them to high temperatures, and we lose them. So sections are required to be thinner, like for example in an electron microscope. Yes, we need ultra thin sections for us to be able to demonstrate and see the features that we are interested in. There is a difference between electronic microscope, which I know you are aware, and the light microscope. And even the embedding and the fixatives we use in electron microscopy are not the same as that we use in the light microscope. We shall cover that. So the infiltrating medium is not sufficiently hard to support the tissue, and then we like for example in the bone, we need to choose the infiltrating material or substance that can match with the type and the nature of the tissue we didn't need to impregnate. For tissues which are very hard, they would really need to have infiltrating medium, or for example if you're using paraffin wax, with higher density and not with a low density. So others that we may use, we may use a substance like the resin, and this is used exclusively as an embedding medium for electron microscopy. We were saying that we mentioned in our previous slide that electron microscopy will need ultra thin sections for higher resolution and the undecalcified bone. But even the medium of infiltrating, we also use resins. We are not going to use wax for that case. Another medium that we can use is the agar gel, and the agar gel alone does not provide sufficient support for sectioning tissues. Its main use is as a cohesive agent for small friable pieces of tissue after fixation, a process that we call double embedding. When fragments of the tissues are embedded in the melted agar, they are allowed to solidify and trimmed for routine processing. Another medium we can alternatively use is what we call gelatin, and this is primarily used in the production of sections of whole organs using a modification of the Goldthwaite technique in combination with agar or a pre-embedded medium and the frozen sectioning. Then we have colloid and colloidin. So the colloidin is used when processing dense and or hard tissues. The use of colloidin or low viscous nitrocellulose requires special equipment and non-conventional microtomy technique and is not suitable for clinical histological laboratories, but rather this can be used for research purposes. So with our interest in clinical diagnosis, we may not put a lot of emphasis on this. And then our very last step in tissue processing is going to be embedding. So embedding, just like I mentioned before, this is a process of creating the tissue block by using an external support medium to enable microtomy take place. So here we need now to make a block where you have the tissue is going to be surrounded by now the solidified paraffin wax, and this shall be done with the aid of a mold. Molds are of different types and shapes, but we shall look at them in detail when we look at embedding specifically. So the embedding medium should be completely compatible with the infiltrating medium in order to prevent tissue section separation and to facilitate sectioning. I mentioned this before, that when you're making a choice of the infiltrating medium, you must also consider the embedding medium. So these must be all the same so that there is uniformity and they not actually cause separation and make layers in the sections. So the best or what is routinely used as an embedding medium is paraffin wax, just like we preferred it when we were doing impregnation, and because it is the most preferred for impregnation in histology, and now even in embedding it will be the same, because we said what we use in impregnation must be the same so that we don't form layers and we don't cause separations. So most laboratories use modular embedding centers, which consist of paraffin wax dispenser, a cold plate, and a heat storage area for molds and processed tissue. We shall look at an image of this modular embedding center where all these sections are. Technology has made it possible that we can have all these three in one unit, where we have the molten wax dispenser is kept at a temperature about 2 to 4 degrees higher than that of its normal melting temperature, so that it can be easily dispensed in the mold. And then it has a cold plate, and this is where we actually, after pouring after dispensing the molten paraffin wax in the mold and putting our tissue, orienting it well, we transfer it to the cold plate, and this allows the paraffin wax now to solidify and make up a mold. So what happens, we shall look at in details how we do this embedding process practically if we get to the lab and do this practically. But moving on, paraffin wax is dispensed from a nozzle into a suitably sized warm mold, and this will choose the size of the mold depending on the size of the tissue you have in the cassette. So you look at the cassette, you look at the size of the tissue in there, and then you make a choice of the mold that can actually accommodate the tissue without going over or filling up the mold. So the tissue is oriented in the mold, fixed to the bottom of it using the cold plate. Remember I mentioned the cold plate. Once we insert our tissue there, we put it in the cold plate so that during how we have aligned it, how we have placed it, can get stuck on the mold. And then a cassette is placed on top of the mold and completely filled with excess wax. So this final tissue block is then placed on the cold plate to allow the paraffin wax to solidify and then form the mold. I mean, not a mold, but form the block. So this is an image of our embedding station, and I'm going to point at a few things. So we talked about a warm area. So this is the section which is kept at a higher temperature, and when we open in here, this is where we can keep our molds. We pick our molds from there. We can also keep some cassettes there, but mainly the molds are kept here. They are kept warm for reasons that we don't want the wax to solidify on them. So this is a cold spot, and this cold spot here is important for orientation, for orienting our tissue. And this is the wax dispenser. The wax will be dispensed. There is a dispenser here. I think it's not seen well, but this is the dispenser here. So you place your mold under the dispenser here, and then you press. There is a button here. So when you press on it, the wax will be dispensed in the mold, and then you can pick your tissue, insert it in the mold, and on this cold point you orient the tissue. So after you have oriented the tissue very well, you put the cassette on top of your mold, continue dispensing the molten wax, you fill up the cassette, and then after you transfer it to this cold plate. So this is a cold plate which will allow the molten wax now to solidify and form a tissue block. That's how this embedding station works. So the resin embedding, this process is similar to paraffin wax. Embedding, however, these blocks are hardened or they are polymerized with heat, ultraviolet light, and chemical catalyst, depending on the type of resin used. And remember, we previously said that the resin it does not solidify easily and does not make hard solidifications like the paraffin wax does. So that's why we need to actually now have to add additives to make it solidify properly, and some catalysts to make it able to make hard tissue blocks that will be used for sectioning. So briefly, we talk about tissue orientation, and this is simply the order of how we lay or we put our tissues in the mold as we prepare for sectioning. So the ability to see the desired tissue morphology in the section is dependent on the correct placement or orientation of the sample in the block. So incorrect orientation may damage diagnostic tissue elements during microtomy or obscure them from microscopic view, preventing a correct diagnosis. So products are available which assist with the proper orientation, like for example marking systems, tattoo, dyeing, biopsy tags, sponge, and papers. These can be used to orient, like when we are grossing, we can use ink to mark. Like for example, if I can bring an example, if we are grossing the breast, we may need to mark the edges, the margins, the anterior, the posterior. So we can mark them with different dyes, green, black, yellow. So when you see black, you know this is the anterior of the breast, and then when you're orienting, you can orient it properly in the mold so that when it is sectioned, we can easily not miss out the features of interest. So orientation of the tissue should offer the least resistance of the tissue against the knife. So this is also very important. when we are orienting, we also need to put it in mind about the next step in tissue processing, which is now going to be sectioning. And we are saying that the position or how we orient the tissue, we should put in mind that it should not meet resistance with the knife, because should it meet resistance with the knife, then it means we are going to get poor sections, either with lines or they are going to be compressed, and this will make us get bad sections and they will not be diagnostic enough. So long tissue samples should be placed diagonally if in a block rather than cross-sectional, as margins of the embedding medium around the tissue provide another additional tissue support. So we shall look in the details at orientation. I will make a presentation about orientation, and then we shall deeply look at how practically and with demonstrations how we can do this orientation, and we will all appreciate. So I just encourage you to look out for my next presentation on tissue orientation, and then we shall appreciate very well how we do this diagrammatically with good illustrations. So tissues requiring spatial orientation may include the tubular structures like arteries, veins, fallopian tubes, vas deferens. Cross sections of the wall and lumen should be visible. So we need to orient them in a manner. That's what we need to do. We shall look at this in details. So skin biopsies, embedded shape biopsies on edge, and punch biopsies on the other side, on their side, so that all the epidermis, the dermis, and the hypodermis are visible. So this is very important. How you put your tissue in the mold should make sure that at sectioning, all these layers can actually be demonstrated. You put in a wrong way, you can only see one layer, and you may miss out some of the very important features on other layers. But we shall look at this. Just watch out for my next presentation that we shall be talking about tissue orientation. Like for example, intestine, gallbladder, and the other epithelial cells orient so that the epithelial surface is cut last, minimizing compression and distortion of this layer, because it is very significant in diagnosis. So this is very important. The epithelium is very important in histology, so we need to make sure and ensure that at least it is visible enough. So multiple tissue pieces are placed side by side with the epithelial surfaces facing in the same direction. That's very important. We don't heap them on top of the other because they are small, because when you just heap them together, we may miss out on the different features. But we lay them side by side and with the epithelial surface facing in the same side. That is very important. So for now, I will end my tutorial here, and next presentation that we are going to do next, we shall look at the automatic tissue processor, and we see how these automatic processors operate, their advantages and disadvantages. So I want to thank you for actually watching today, and I encourage you for continuing to look out for my presentation, my tutorials. You subscribe, press on that, click on that bell and subscribe, so that you can be the first person to know when I make the next presentation, when I upload the next video. Also share with people so that they can also benefit from these tutorials. Thank you. Don't forget to like, and I want really to appreciate your support when you like, share, and subscribe to my YouTube channel. Thank you so much, and goodbye for now.